rounds on these grand rounds. So welcome to everyone. We hope you had a decent Thanksgiving in spite of us not being able to gather in the way we're accustomed to, but we hope it was good for you and yours. Let me remind you of our upcoming rounds in the new year in January. On January 7th, we have two of our early stage investigators. One is our own fellow, Anthony Santoro, who will be talking about environmental stress and neuropsychiatric outcomes in people living with HIV in low resource settings. And the second person with the title of the presentation still to be determined is Ankanksha Anand, who is from Fordham University School of Social Services. So that's January 7th. And then January 21st, we have someone that many of us know, and he's a senior advisor to our center, Charles King from Housing Works. And he'll be talking about homelessness and harm reduction from HIV through COVID. So that's our January 2 rounds. I'll wish everyone now happy December holidays, because this will be our last rounds before. No, wait, we have another one, Teo? I'm sorry. That's it, right? This is our last one?
Yep, that's for January.
Yeah. So that's why I'm saying happy December holidays to everyone. So just a reminder during this presentation to keep your microphones muted. You can put your name or question in the chat, and then we'll take those in order when it's opened up for discussion after approximately 45-minute presentation. And if you're on the phone and you can't use the chat, at that point when we open it up, you can unmute yourself and ask your question. And we'll be moderating that discussion, Stephen Sukumaran and or myself. Okay, so today we're very fortunate to have Dr. J.D. Smith with us for today's grand rounds. J.D. Smith is an associate professor in the Department of Population Health Sciences at the University of Utah School of Medicine, where he just really started there this fall. He completed his Ph.D. in clinical psychology at the University of Tennessee, Knoxville, followed by a 2-year T32 postdoctoral training program at the Prevention Science Institute at the University of Oregon, and a 1-year postdoctoral fellowship at the Reach Institute at Arizona State University. JD, we're glad and thank you for spending time after this round to talk with our current fellows. I'm sure they can benefit a lot from your experience. Prior to joining University of Utah, which, as I said, was just this fall, Dr. Smith was associate professor in the Feinberg School of Medicine at Northwestern University in Chicago from 2015 to 2020, where he served as associate director of the NIDA-funded Center for Prevention, Implementation Methodologies for Drug Abuse and HIV, and co-director of the Program in Dissemination and Implementation Science in the CTSA there. Dr. Smith is an implementation science methodologist and a clinical health psychologist. He is lead implementation scientist on multiple projects that are funded by multiple institutes, NCI, NIAID, NIMH, HRSA. And he does this across a broad range of topics, including implementation of interventions for pediatric obesity, pediatric and adult hypertension, mental health across the lifespan, cancer prevention, and of course, HIV prevention and treatment. On a more personal note, I'll say that JD has been extremely helpful as a consultant to several of us for our EHE implementation science NIH funded projects. And we're very grateful for him. He's a great teacher. And so I will turn it over to him today to talk to us about implementation science and HIV. Where are we now and where is the field going? So over to you, JD. Thank you so much for being here.
Yeah, thank you. And thanks for the kind introduction. It's really a pleasure to be able to speak with you guys and share some of this work that we've been doing. So as the title really alludes to, I'm going to take a little bit of a stab at where things have been over the last 5 or 6 years with reviewing a mapping review that we published earlier this year in AIDS and Behavior. And then also talk a lot about the ISKI and some other implementation science related issues that have come up in the ending the HIV epidemic. So that's kind of a little bit of where we're going. I can't go too far into the future, but at least some of the immediate future. So just a whole bunch of acknowledgements around mostly different funding sources that have funded the HIV-related work that I've been involved in over the last few years. I also want to specifically give a thanks to Chris Gordon at NIMH and David Purcell at the CDC, as well as Brennan Kaiser, who's a part of our team at Northwestern, for contributing slides for this presentation. So just for folks who may be new to implementation science, and just for all of us anyway to get all on the same page, I wanted to start with a very, very non-scientific and straightforward definition of what implementation science is. I'm not going to talk too much about some of these terms during the talk today. We'll just talk more generally about implementation science, but I think this is still helpful. So this is a slide courtesy of Jeff Curran that was published in Implementation Science Communications. So he says that the innovation, intervention, or practice that we are trying to implement is the thing. Effectiveness research looks at whether the thing works. And typically we're talking about it working to prevent new infections, to improve symptomatology, to reduce the likelihood of diagnosis, all those kind of things. So it's really patient level clinical outcomes that we're concerned about in effectiveness research. Dissemination and implementation research, however, looks at how best to help people and places actually do the thing. So those who wish to adopt and deliver a practice or intervention, what do we need to actually do to help support them to do that? And how do we change the systems in which they work to be amenable to that new innovation as well? So the stuff that we do are implementation strategies. So there's a whole multitude of different implementation strategies out there, but it's what we do to try to support and help people and places do the thing. And then, of course, we measure how much and how well we're doing the thing within a healthcare delivery system by measuring implementation outcomes. And we will talk a little bit about implementation outcomes because, as you'll see, there's some issues in the field about them. So I want to also kind of point out a couple of recent quotations. And I know that the best kind of self-love is self-citation. So I have a quote here from one of our papers. And really the point here is that in the field of HIV, it's almost all about implementation at this point. Certainly there's still room for innovation within the field. There's room to find a cure, of course. But basically what we said in our paper from 2019 is that in 2019, the requisite biomedical and behavioral interventions to eliminate new HIV infections exist. Ending the HIV epidemic now becomes primarily a challenge of will and implementation. Elvin Gang and some of his colleagues had a almost simultaneously published paper in PLOS Medicine where they made it almost exactly the same point, maybe more well written. Elvin said, "We have arrived at a moment in the global HIV response where implementation research is ready to take center stage. Perhaps more than ever before, success in the global HIV response depends on the effectiveness, efficiency, and quality of implementation." So this is kind of leading us into where we are now, which is we are about a year and a half into at least the formal funding. It's been a little longer than that since it was announced that there would be this Ending the HIV Epidemic initiative across the federal government to try to end HIV. The overall goal of EHE is to reduce the number of new infections by 75% by 2025 and by 90% by 2030. So a lot of what we're talking about today is the implementation science that's needed to actually reach these pretty ambitious but still realistic goals. So within the Ending the HIV Epidemic, there's sort of a couple premises here that we have access to the most powerful prevention and treatment tools in history, prevention technologies and different strategies that help us identify where the services are urgently needed. But the only way to actually make the impact we need is to equip communities at risk with the tools to end the HIV epidemic in America. This does apply globally as well, but certainly the domestic HIV issue is the forefront of the EHE initiative. And really this piece right here that connects these powerful tools with the equipping the community, this is all implementation science. So to be able to actually achieve this, we need implementation science. Everyone probably is fairly aware that EHE set out 4 different pillars. They have a diagnose, treat, prevent, and respond pillar that we will come back to at certain points. But essentially, these are four different places in kind of the disease progression and the prevention spectrum, where we have evidence-based interventions. We have things we know can help achieve the goals of diagnosing, treating, preventing, and responding to outbreaks. So it's an issue of implementation at this point. So why is implementation science needed? This was a slide from David Purcell that I thought did a really good job of kind of capturing at least the federal government's perspective. They basically say we have the highly effective tools. The tools are not fully integrated or implemented into routine care, which I think we all probably are very aware of. We also know that there's a lot of disparities that exist in terms of who's aware of these new innovations, who has access to them, both at the patient and provider level, and who is actually benefiting from these tools. And I think, nothing is maybe more illustrative of this point about inequity than the high number or high disparity between racial and ethnic groups and who is actually on pre-exposure prophylaxis at this point, which we know is a very effective preventive tool. So implementation science can help us to identify the implementation strategies that are effective at improving uptake and use of these tools. And it can also be used to help identify the critical barriers and facilitators that we know are going to either help or hinder the uptake and use of these tools. So what is the state of the field? And what I'd like to do here is actually kind of go through some choice results from this landscape of HIV implementation research funded by the National Institutes of Health. This was a mapping review of project abstracts that we published in AIDS and Behavior in early 2020. And I think we learned a lot about at least the more recently funded projects, which we went back for about 5 years within this. So the purpose of this mapping review, as well as some of the key definitions that we used, we wanted to identify the proportion and describe the characteristics of HIV-related implementation research studies that were funded by NIH since 2013. We did this review in 2018. So as I mentioned, we have a little over 5 years of actual funded work that we were able to cobble together for this. We defined HIV-related research as studies that measured an HIV outcome related to the prevention or care continuum indicators, and this would include things like PrEP awareness, linkage, retention, adherence, and HIV risk reduction. We use the two different kind of definitions of implementation research. We use the NIH-defined implementation research as well as implementation preparation research, and I'll define those a little bit better here in a second. And lastly, our purpose really was to establish a baseline from which we could monitor progress and evaluate the impact of some of the different initiatives and efforts that are underway to train and provide more resources for implementation researchers in the field of HIV. So as I mentioned, these two different definitions of implementation research, we took a very inclusive view to make sure we captured kind of the whole universe of NIH-funded implementation research. So the NIH definition is that implementation research evaluates the use of strategies to integrate interventions into real-world settings. So really the key is that they're evaluating the use of strategies, which typically involves some kind of a test or evaluation. It could be observational, but for the most part, these NIH-defined research studies use more experimental or quasi-experimental designs, because the intent is really to test one strategy against another, or novel strategies against usual care. But we also included research that would be considered kind of in the implementation preparation phase, or said a different way, it's really research that's being conducted prior to fully testing an implementation strategy or implementing a new intervention. So this could be things like research that is only understanding the implementation processes or barriers and facilitators. So they're not actually implementing, but they're understanding the context and what's happening. It can be preliminary research on the feasibility or acceptability of new strategies. So not actually implementing them, but getting stakeholder feedback, potentially picking from a menu of options that are going to be studied in a later trial. This could also include formative research to develop or tailor novel strategies, but not actually going as far as testing them. It can also include adapting. So adaptation is actually an implementation strategy in and of itself, but often we figure out how to adapt and what needs to be changed prior to actually fully testing that strategy. And we can also use simulation. Simulation modeling obviously is not real. It can closely approximate the real world and give us a sense of what will happen. But in this case, modeling that's used that has the potential to inform real implementation research, but is not actually doing it. So in the end, I'm going to save you the pain of going through a Prisma diagram or a flow diagram. And I'll just say here, we identified 594 studies that were HIV related. Of those, there were 216 that were both HIV studies and one of the implementation research definitions. And it was almost evenly split. So about 107 were in the implementation preparation phase, 109 were in the implementation research phase. So one thing that's kind of interesting is only 18% of overall HIV studies that we identified were implementation research related per the NIH definition, which we think is really kind of an indication that there's a lot of room for more funding in this area. And that this is a metric for us to track how much implementation research is being done within the broader portfolio of HIV related research. So just in general, here's some grant characteristics by implementation phase. So you can see on the left bar graph in terms of the actual start date, so the funding year of these different grants. You can see a kind of a nice steady increase from 2013 up to 2017. There's a weird little 2016, 2017 blip there for some reason. But for the most part, we see a pretty steady increase in the number of funded studies that are HIV and implementation research. The pattern of kind of preparation versus implementation is, probably not terribly meaningful, but in general, the number of studies is going up. In terms of the actual project code, perhaps not surprisingly, many of the R01s that we saw, so the larger grant mechanisms, were in the implementation research phase versus preparation. These are larger studies, obviously, still have potential for large-scale trials. And then we saw a number of U series and then small R series grants. And I think pretty clearly in the small R's and the K's, we would expect more implementation preparation work just because of the size of the budgets. In terms of population characteristics of the different studies, we coded who was being targeted. You can see that women and MSM are high on the list, where we see newborn pediatric, sex workers only, and Latino only kinds of studies are kind of the less represented within the study populations. In terms of HIV status, we were interested in whether or not they were targeting HIV positive populations, HIV negative only populations, targeting positives and negatives. And we had about 13 studies where it was not specified from the project abstract. We couldn't ascertain what their population was in terms of HIV status. And you can see it's about a third in terms of the actual ones that we had data from. We also coded the step along the HIV continuum that was being evaluated. So this kind of gives you one sense. So there were 57% of the studies were only looking at one step in the care continuum. And the vast majority of those, 59%, were purely prevention. There were 20% of studies almost that were looking at antiretroviral use to get people to a non-detectable level. And then there was a lot of studies, 43%, that were actually looking at more than one step. So typically, yoking things that are related in the care continuum, like HIV testing and linkage to care, which was the most common two-step study. We also saw a number of retention and ART studies, as well as prevention and testing, prevention, testing, and linkage. You can see there with the. So in terms of getting into the implementation science of these different studies, there were a number of different kind of study types and aims, and we kind of mixed them together a little bit since it was difficult sometimes to split them apart. So we came up with a number of different categories to talk about the study aim and type. So we found that there was about 27% were evaluating the impact of an implementation strategy, which by the definition of implementation research is exactly what you would want to be testing, at least in part. We also found that there was 21% of studies that were had at least one aim that was looking at barriers and facilitators of implementation, which is not surprising. It's a necessary step for a lot of implementation research. We also saw that there was a lot of studies that were doing the development or adaptation of implementation strategies, likely to be tested again in a later study. And then also the kind of farther end of the spectrum, which we'll get to in a little bit, is comparative implementation, where you actually have multiple options of active implementation strategies kind of pitted against one another. You can think about this as really similar to comparative effectiveness research, where you have two bona fide interventions. Comparative implementation tries to have two kind of bona fide implementation strategies that compete against one another in a sort of head-to-head trial. And then you can see too that we have some adaptations of the intervention, which is not really in the same, it's not quite as far along in the implementation research spectrum. And then some things about feasibility and acceptability. So getting into implementation outcomes, I mentioned already that this is one of the areas that we focused on. This is in the implementation preparation studies. So there's 107 of those total. We categorized 13 different implementation outcomes. So we have kind of the standard 8, which is acceptability, adoption, appropriateness, cost, fidelity, penetration or reach rate, and maintenance or sustainability. The others that we saw and also wanted to make sure that we were capturing, being kind of over-inclusive about whether or not it counted. We also included determinants as outcomes. When they said we were going to study the outcome of implementation, which we think is probably adoption or uptake, we allowed that to count. We looked at implementation process, scalability, speed, and effects on systems or system effects as implementation outcomes. What we saw is that in the implementation preparation, that it was largely only 1 or 2 implementation outcomes mentioned. So 83% of studies had either 1 or 2 implementation outcomes, 17% of studies had 3 or more, but really it's only 3, 4, or 5, which is not terribly surprising. In implementation preparation, there is 4 or 5 really common outcome metrics. And maybe it was just that there was a focus on 1 or 2 in these kinds of studies. One thing that was kind of challenging, though, we found this across both of the different kinds of studies, is that even in the implementation preparation, there was 28% of studies that did not actually have an implementation outcome. So they were actually looking only at participant level impact metrics like you would do in a clinical trial, despite the fact that their study was an implementation study. So we'll look at this again in the implementation research studies. So this is the 109 implementation research studies that were meeting the NIH definition. You can see a little bit more implementation outcomes or like higher frequency of having multiple within a study. So only 68% have 1 or 2, and 32% have 3 or more. So that's more what we would expect for this later stage of implementation research. Not surprising. What is surprising, however, though, again, is we see this high number, at least what I think is a high number for implementation research, where there were no explicit implementation outcomes mentioned, yet they said their primary outcome was a participant impact metric, and it was assumed that that was the only primary outcome. So you can see that there's room for us to improve on people's measurement of implementation outcomes, even within implementation studies, which again, probably just needs training. So again, looking at kind of the frequency of different kinds of implementation outcomes, I just want to show this side-by-side comparison to see a little bit more granularity. And this does align really well with the stage of research. So in preparatory research, some of the more common metrics are acceptability and feasibility. We see those very clearly as the most common ones being evaluated. Within implementation research studies, it should flip a little bit. And we did see this, that things like cost, as well as acceptability and feasibility, of course, are still pretty relevant here. But cost and sustainability and fidelity start to take on a slightly higher percentage of the number of outcomes that are being evaluated. So this is an implementation research continuum that we developed and coded some of these different studies into. This is not meant to be necessarily like an endorsement of higher on the continuum equals better. It just really is, as you're going through kind of the developmental phase of testing implementation strategies, this is possibly one kind of continuum that you might go through. So in implementation preparation, we are often doing things like assessing various facilitators, doing developmental and formative work, and conducting pilot studies. And you can see that in terms of our pilot studies, actually, sorry, I'm gonna go here. So in terms of our pilot studies within the preparation phase, Most had implementation outcomes, many did not, and that's kind of disappointing. On the other side of things, we move into kind of the implementation research phase. We have tests and trials of implementation strategies, and then we have that class of comparative implementation. And you can see here that there's a pretty high percentage of studies that, again, even at these later stages, are not including implementation research outcomes, at least in project abstracts, which you would think if it's the primary outcome, that would be mentioned in the abstract. And then here within this entire thing of the implementation research phase, it's actually almost 50% or almost exactly at 50% that do not have implementation research outcomes, which is a bit perplexing, but just a finding at this point. Just to, for those of you who are interventionists in this field, thought it might be interesting to look at a couple of interventions and kind of what kind of funding was being done within those. PrEP is a really great example, a relatively new intervention, part especially back in 2013 to 18 when these studies were funded. You can see the vast majority of PrEP-related studies are in the kind of early implementation preparation phase, and then less in kind of the comparative effectiveness implementation, which is really in kind of striking contrast to something like retention, which has been around for a lot longer. There are much less preparatory research studies, much more kind of at the later stage as we're trying to figure out exactly how best to implement it. So a few limitations of this mapping review, some of which are kind of obvious. The coding was based on project descriptions, so it may not contain sufficient detail of all the implementation related variables, which is why we may have been missing some of those implementation outcomes. Also, just focusing on NIH reporter and pulling funded projects means that there's potential that we under-included and underestimated, despite the fact that we were very generous in our coding in terms of what was actually included as an implementation research study. And then also the actual characteristics, as I mentioned, even mentioning anything related to an implementation outcome, we counted. The other thing that was kind of striking is there's a really big lack of uniformity in abstract content, as you probably would imagine across lots of different projects. But basically it meant that there was not always the same information in each one of these different abstracts to pull from. And we also recognize that going to NIH reporter means it does not reflect the universe of HIV research studies. There are other funders, and there is unfunded research that, of course, does not show up in the NIH reporter database. So where are we headed? This is sort of ongoing and planned HIV implementation science initiatives, and I'm focused mostly on the United States here. And you'll see why here in a second. This is very much focused on the Ending the HIV Epidemic initiative and the kind of the funding that they have put forward to try to integrate implementation science into this effort. So just a tiny bit of background. There was a federal implementation science work group that was actually has been around before 2019, but as of 2019, it looked kind of like this. So in 2018, the CDC, NIMH, and HRSA started working together on an implementation science working group to go cross-agency and cross-department within the federal government. The EHE announcement that they kind of came up with highlighted implementation science and identified NIAID as the kind of NIH funding mechanism to support implementation science through the Centers for AIDS Research. And I'll talk more about that here in a minute too. So the Federal IS Working Group has continued to expand. In team, they added NIAID, they added representation from NIDA and from the Office of AIDS Research as members to the IS Working Group. So the goal of the Federal Working Group is to support collaboration, idea sharing across the agencies and departments, and to also minimize any duplication of federal efforts. Since then, NIAID has funded supplements to the CFARs and the ARCs, the AIDS Research Centers, for work with the EHE jurisdictions to support implementation science. That's what I'm going to go into here in a minute. So for folks who are not familiar, which I imagine most of you are familiar with, at least the CFARs, so the CFARs were selected in large part because they foster high quality multidisciplinary HIV research by increasing collaborations within institutions in a cost-effective manner. That's the whole point of the CFAR mechanism. They're really an infrastructure support, and some of the key components are really that they provide services and expertise. They support early career investigators. They add value to HIV research that's being done at those institutions, and they provide economy of scale. A very similar funding mechanism is the NIMH-funded AIDS Research Centers, or ARCs. And these are an infrastructure system to support high-impact science on the mental health issues that are related to HIV infection. And so some of the key areas of the ARCs are development and testing of feasible and cost-effective interventions, methods to improve sustained adherence to drug therapies, and use of implementation science, actually specifically, which was in the development and testing of strategies to achieve public health impact of mental health interventions related to HIV infection. So these were the two kind of large federal mechanisms that were already in place, that were selected as sort of the conduits and the places to identify people who could be trained to do implementation research in HIV, and to push out these pilot funding or planning grants and other EHE grants that I'll talk about here in a second. So the role of the CFARs and the ARCs in the in the EHE initiative is that they both serve as the research platforms to support implementation science. They also work closely with communities to identify the local needs. So each of these are within a EHE jurisdiction, and they work with community partners to figure out what the local response should be. They also allow for really good collaborations with CDC, HRSA, Indian Health Service, as well as SAMHSA-funded partners to investigate how best to deliver these evidence-based interventions and services. And they can also be a great conduit to inform local partners on best practices. So really used as a dissemination source as well for when we have new state-of-the-art biomedical research findings. So yeah, I'll mention this, the ISKI effort here in a moment. They also are used to collect and disseminate data on the effectiveness of the approaches used within the EHE initiative. And as I mentioned, well, as I'll talk about too, the ISKI initiative that was funded as a coordinating center is meant to kind of bring together and synthesize a lot of those different effective approaches across the CFARs and ARCs. So probably a map that you've all seen. This is the CFAR and ARC sites, at least as of June of 2018. And they are highly corresponding to the counties and states that have some of the highest outbreaks and highest incidence rates of new HIV infections. So one of the first things that happened with the EHE initiative was the funding of implementation science supplement awards. Now, they had to be associated with a Center for AIDS Research or an ARC, and also had to be addressing one of the 4 pillars of the EHE initiative, also with populations that were in one of the EHE jurisdictions, which are those high incidence rates jurisdictions across the country. So in 2019, there were 65 planning projects that were awarded, including the ISKI Coordinating Center that is housed at Northwestern University. In 2020, these were just announced within the last few months. There were 12 two-year projects, and these are actually all coming off of one of the planning projects that was awarded in 2019. So these are kind of building from that prior work. They also funded 9 one-year projects, which were either new projects or were extensions from the 2019 projects, where likely they hadn't made enough progress to warrant a 2-year project at that point. There were also 2 kind of unique initiatives added in 2020. So there was a mechanism focused on HIV prevention for cisgender heterosexual women. They funded 7 grants in that area. There was also a special topic on data-driven messages and communication, in which 6 grants were funded. And again, we received renewal funding for the ISKI Coordinating Center, as well as now expanding our efforts within the coordination and the kind of HIV training that we do, HIV implementation science training, to 5 regional coordination hubs that are located, or at least associated with Johns Hopkins, Yale, UCLA, University of San Francisco, the University of California, San Diego, that's a typo, and the University of Alabama, Birmingham. And each of those were assigned a number of different projects from the 2020 awards to oversee. So here you can see some of the PIs, as well as the CFARs and ARCs that were associated with the hubs. So in terms of the 65 planning projects, just to give you a sense of the dispersion of these, where they were actually located, you can see they are next to, obviously, the Centers for AIDS Research and ARCs that supported the awards. You can see the different color coding has to do with the project pillars. So whether they were a project focused on diagnosis, on treatment, prevention, and response, or whether they were addressing multiple pillars. The vast majority were addressing multiple pillars, but you can see some examples of 3 different response ones that were in Southern California. Also a number of treatment only ones that were associated with the Johns Hopkins CFAR or the DC CFAR. The 34 projects that were funded in 2020 have a relatively similar distribution. You can see that there's a couple in Florida, a number in the Northeast, a number in the Midwest states and the South, and then a couple over on the West Coast. This is just to give a sense of kind of where the project funding is going in response to the EHE jurisdictions. This is a little bit of a busy slide, but just to give a sense, this is kind of the crazy Venn diagrams around the 4 pillars and what is being addressed within the planning projects from 2019, and then what is currently being targeted within the 34 year 2 projects. And you can see that there has been actually some major shifts. So very few diagnosed projects within the 2019 award period, many more 20. And then also a lot more kind of overlap of addressing both treatment and prevention simultaneously that we saw here. And then a huge increase here too in prevent and diagnose compared to over in 2019. So we did a little bit of querying and also coding of applications around some of the implementation science and intervention characteristics that are associated with these different studies. So in year 1, we coded the stage of implementation research using the EPIS framework, which has to do with exploration, preparation, implementation, and sustainment. And you can see these year 1 planning grants, not surprisingly, the majority of which focus either on the exploration phase or preparation, which is kind of really early stage implementation. In year 2, in large part because some of the exploratory work had been done and a lot of the 2019 awards were kind of renewed or extended, I guess. There's a lot more in preparation and a lot more in implementation now than there was in the 2019 planning grants. So that's good to see. So now I'd like to talk a little bit about the ISKI piece of the EHE. So ISKI stands for the Implementation Science Coordination, Consultation, and Collaboration Initiative. And again, this is a center that is housed at Northwestern University. So it was funded to provide these coordination, consultation, and technical support services for all of the EHE supplements, both from 2019 and now from 2020. The aims are relatively straightforward. We wanted to support high quality implementation science in the funded EHE projects, largely through technical assistance from experts in implementation science design, use of frameworks, evaluation of strategies, implementation science outcome measures, and actually identification and operationalization of outcomes as well. And we also wanted to create opportunities to develop generalizable knowledge from the local knowledge that's often gathered by these small projects, by encouraging the use of shared frameworks, harmonized measures, and also actually doing data synthesis across the projects once we have some of the outcome data. And we also wanted to provide a platform for cross-project collaborations that might not otherwise exist. So the role is really to collect and report on project milestones and outcomes to the NIH across all the EHE projects that are funded, to encourage the cross-project collaboration and the shared use of implementation science frameworks and measures and outcomes, and also optimize data harmonization so that we can actually do synthesis when appropriate. And then lastly was really to provide training on implementation science concepts that were relevant to the ending HIV epidemic. So here's the core team currently. So the supplement PIs are Brian Mustansky and Annette Benbow, who are both associated with the Center, or the Third Coast Center for AIDS Research at Northwestern. And then myself, Dennis Lee, Hendrix Brown, are co-investigators. And then we have 2 excellent project coordinators in Brennan Kaiser and Juan Villamar. So there, at least in the sort of data to show kind of that there is really a need for this kind of implementation science training and coordination. So we polled prior to actually doing any of our training efforts, the implementation science experience among the 65 funded projects in 2019. And what we asked them is, what previous implementation research experience do you have? Actually, majority, unfortunately, but 20% had none. Some had other experience, but really we saw kind of a low level of being involved in funded IS projects or having done program implementation, evaluation, or quality improvement kinds of projects. So there is definitely some methodologic and conceptual overlaps between QI and program evaluation, but certainly not quite the same as what's happening in implementation science. We also asked what previous formal training did they have, and unfortunately it was pretty low. Some had attended workshops, some had a graduate course, some folks had said they were self-taught. There was a other category, but again, a pretty high proportion, more than a third, had no formal training at all in implementation science. So this is kind of to show you how we envisioned the ISKI collaborative actually working and being able to achieve our aims while training up these EHE funded projects. So we have a number of different teams that obviously got their funding through the EHE initiative. So the ISKI program actually provides a community of practice that involves multi-component training and resources. So the community of practice has tons of resources that we made available to folks freely on our website. We conducted a number of different webinars that were really intended to be sort of training focused. We held a brief implementation science reading course, myself and Dennis Lee. For those who were interested, it was not, and the majority of these are not required activities to participate in. We also have an online discussion board where people can ask questions and we can learn from group wisdom. We provided individual and group-based coaching to different projects. And then we also collect data and help to actually do that data harmonization. What we think is going to be the product of this community of practice is that we would have stronger implementation science grants that are proposed. We would have more generalizable knowledge because the ability to have some common data elements and synthesize, and hopefully just better, kind of rigorous implementation science in general. So in terms of the resources and services, we provide technical assistance. We had a summit that we organized people into small groups and did a lot of training there. We focused our training on the implementation research logic model. That is a paper that myself, Dennis Lee, and Miriam Rafferty published actually just a couple months ago. We provide a ton of online resources, webinars that are recorded and made available. And again, the reading course, discussion board, and individual coaching. So some of the products that ISKI is trying to accomplish over the next couple of years is creating and providing a lot of training materials. So this primarily falls in the webinar and kind of worksheets or handouts kind of format, but we hope that we can provide a bunch of different training materials that are useful to folks. Another project that is well underway, and actually we have done a webinar on it and also made it available internally, but are now preparing it for publication so that it's consumable by people who are outside of the EHE funding sphere, is we developed a standard set of implementation outcome measures and measurement strategies that are based on the REAIM framework, and also divided by the HIV pillar, as well as the stage of implementation research. So it's kind of a grid. You kind of look for what pillar are you addressing, what stage of implementation research are you, what implementation outcomes do you want to measure, and we are providing with sort of what we call the required. So if you're doing HIV testing in the implementation preparation phase, you're required to measure X and Y implementation outcomes. However, it's also conceptually accurate and would be recommended that you might also evaluate Z outcome, and then there's a bunch of optional ones that we also provide. So it's very comprehensive, maybe overly comprehensive. I can't tell you how many hours and people, manpower went into actually just discussing and making sure we have these accurate, but it should be a great resource for the field. We also coordinate all the activities of the hubs. Sorry, I should say 5 hubs and ISKI, so it's 6 groups, and all of the current 34 supplement projects. We also continue to work with some of the 65 planning projects, even though most of them have actually finished their funding. But we would like to continue to see them submit for different funding mechanisms and get their work funded so that it obviously gets done. We are also conducting 2 different systematic reviews, one on the determinants, that's kind of the broad term for barriers and facilitators related to different HIV interventions in different service delivery contexts. So that'll be a fairly large systematic review. And we were also doing a systematic review on the implementation strategies that are used in HIV implementation research to try to identify common ones and really figure out potentially what ones need to have more use in the field and ones that need additional testing to see if they're effective. We also had recently got approval for a special supplement in JADES that will be focusing on domestic HIV implementation science. So there will be a call for papers coming very soon, and we'll have a 2-stage process of submitting 1-page proposals, followed by a selection of those who will be invited to submit full-length articles that'll be due in June. So there's definitely some time to conceptualize and collect data and get that analyzed for this special supplement. And that is going to be guest edited by myself, Brian Mustansky, and I think Dennis Lee and Annette Venbo will also be involved from the ISKI team. So some key outcomes and challenges of implementation science, kind of within at least the ending the HIV epidemic sphere, but this is very applicable, I think, as well to the global HIV pandemic as well. It's not only specific to the domestic issues. So there is significant knowledge to be gained. I think what we found from where the state of the field was in our mapping review, and also even just the state of the training and knowledge among the funded EHE projects, is that there's a lot that we can still teach the field. There's a lot that the field can gain from kind of the broader field of implementation science and apply to the prevention of HIV. We really need to be able to provide better prospective guidance on implementation science. It's somewhat scant in literature in this area, only slightly better in other areas like mental health, but we can certainly do better here. The field of HIV has only more recently embraced D&I science methods. That was one of our kind of clear findings from both the mapping review, but also just the sense of the number of publications and even things like that have been done in HIV. It's been a little bit of a laggard in terms of embracing these methods compared to some other fields. We really do need better data synthesis across diverse projects. So that is one of the things that the ISKI initiative in particular is trying to address, is gathering data in a way that we actually can do meta-analysis, we actually can do some kind of data synthesis to help develop generalizable knowledge. And this is across things like intervention types, the different contexts and the determinant factors, the different strategies, and even within the different pillars, regardless of the type of intervention that's being used. And really the goal here, I think, and this is, again, one of the challenges, but would be a key outcome if we were able to achieve it, is we need to know more generalizable and translatable implementation science knowledge. It's imperative to have that if we're going to inform wide-scale implementation of effective interventions across the United States. And this would be both behavioral and biomedical interventions. Implementation science knowledge needs to be usable by implementers. That is basically that translation of academic to community. That challenge is certainly still present within the field of HIV, even though we do a great job, I think, in general, of working with community partners, establishing really strong relationships with them, learning from them, having them be active partners. But I think one of the things that gets lost and we haven't figured out yet is the actual translation of the science of implementation to the use and actual application by implementers. And then we also need to know and have better metrics to track the impact and to track progress that we're making in this field. So those are, again, things that we're trying to address and things that would be great as primary outcomes if we're able to achieve them. So that's the end. I just want to say thank you for giving me this time and look forward to some discussion here.
Thank you, JD. That was really really comprehensive and There's a lot packed in there. So again, inviting everyone to put their questions in the chat, and we'll take them one at a time. And if someone, also feel free to unmute yourself and ask your question, particularly those people who are not online with a computer, but on their phones. So the first question we have from Teo Sanford. JD, could you explain what the use of observational implementation science, what use is of observational implementation science studies?
Sure. So I think that the two most common that I see either published or proposed, one of which is kind of early stage implementation, and it's typically done just observing what implementation practices look like within certain organizations. Oftentimes it's with just service as usual. So it's not necessarily the intervention that you're wanting to implement, but let's say that you're trying to implement PrEP, within a primary care clinic, for example. And one of the things you'd want to potentially observe and understand is how do they actually assess for high-risk sexual behaviors and other kind of inclusion criteria, or I guess indications for a PrEP referral or for a PrEP prescription. You may want to actually see what exactly their process and workflow is. The other observation that you might have, the other kind of observational study that you might have is and I think we're actually one of the fields that this has happened, that biobehavioral interventions in particular sometimes move very quickly from innovation to implementation. And there are times that there are federal directives, federal money that goes into the implementation, often funded by HRSA or CDC or someone like that, prior to us actually doing implementation research to figure out how best to implement. So what happens is that these things get pushed out, people start to implement kind of as usual, and that gives us an opportunity as implementation scientists to just see what they're doing. How are they implementing? With a large enough sample, you could actually identify some of the more promising practices. We often do analyses or kind of a research design for this kind of a situation where we look at like positive deviants or positive outliers. So what organizations and individuals are really, really good at implementing this new innovation, and what are they doing? What strategies, what factors were present in their context that made that the case, versus maybe those that failed to implement, right? So maybe they have a higher preponderance of certain barriers. Maybe there's a kind of implementation culture that is not really conducive to new innovations. Potentially there's a stigma associated with something like PrEP in particular, where an organization or a group of physicians or somebody else may just have a stigma around asking about these questions or around prescribing an HIV preventive measure. So those are the two most common observational kind of studies or observational designs that you might see.
Thank you for that. I have a not well formulated broad question, and I know your presentation touched upon this, but can you elaborate and talk more about, around EHE, of course, we're all interested in the outcomes of the pillars, and we're interested in particular outcomes like proportion of viral load suppression or PrEP uptake and persistence, and just talk a little bit about how the outcomes, or in particular the kind of the biological outcomes, are so important to us, but yet this implementation science is really studying, how we're implementing things in the field, and there's other variables that we're focused on. But just sort of in your own words, give us a sense of how we integrate, those kind of primary outcomes that the world wants and embedded in all this implementation science.
Yeah, so I think, one of the things that necessitates this, a little bit of a shift in perspective or shift in emphasis to implementation outcomes as opposed to clinical outcomes. In clinical trials, when we're trying to figure out the effectiveness of an intervention, we really want internal validity. We want to know for sure that we control for every factor that is potentially going to make the, medication or something ineffective. And so we try to control all those things so that the only thing that is possible that could explain the difference between two groups is the exposure to or use of the actual intervention. In the real world, that is not possible. Like that premise just doesn't exist. We can't control the contextual factors. We can't control, everyone's knowledge and self-efficacy about delivery of that intervention. There's a lot of room potentially for inclusion of people who aren't necessarily, or would not necessarily be part of meeting the inclusion criteria of a clinical trial, but yet they still could benefit from the intervention. So for lack of a better term, it just becomes a lot of noise, and there becomes a lot of things that have to do with the quality of delivery of that intervention that has nothing to do with the actual potency or effectiveness of the intervention itself when it's isolated. So maybe being a little bit more concrete, when we try to implement something, there's all these factors that have to do with implementation are basically mediational factors on the effectiveness of the outcome. So if people are not accepting of the intervention, and I say people in terms of the actual service delivery system, if they don't accept the intervention, if they don't think it's appropriate for their setting, if they cannot deliver it with fidelity, if they cannot get it to everyone who is eligible to actually receive it, what you end up with at the end of the day, and we know this, kind of from the perspective of program evaluation, the program itself is not going to have much of an effect. Sure, those people who actually got the appropriate dose of the intervention are likely to benefit, because we know from clinical trials that that is the case. But all those other factors that go into actually doing that at the population level, or the population level, even just a singular clinic, is really what we're focused on. And one of the metrics that we have used in a couple of different studies that really helps put this point forward is called the public health impact metric. And it's a really simple formula. It is the standardized effect size of the intervention that you observe within your study, multiplied by the reach or penetration rate. So what you could easily see is that if you had a 0.5 standardized effect size, which in a clinical trial may not be super great, but in an effectiveness study might be sufficient to actually be saying you're doing a good job, but you're only able to reach half the population, and your reach rate is only of 50%. What the public health impact metric would then actually be is 0.25. You have 0.5 times 0.5, you get 0.25. If you look at actually 5 different implementation metrics, so if you look at the reach of the intervention, the acceptability of the intervention, the fidelity, and then the actual sustainment of the intervention, if all of those are at a 50% rate, your actual overall impact of the program is less than 5%. So it's a less than 5% overall impact. So it's really important for us to understand all these factors that influence how well the effectiveness of the intervention will be when taken to scale. And we can only do that by studying all those implementation metrics. The other thing that's really important about studying the implementation outcomes, and I think we know this, from clinical trials, when we evaluate fidelity and make sure that fidelity is at a high rate, if you potentially have a failed implementation trial, so you go out and you try to implement some new thing, you look at the end of the trial and you're either have equivalence or you're just clearly ineffective. Yet the intervention was shown to be highly efficacious in prior, clinical trials. The explanation that I would come up with is not that your intervention isn't effective, it's that your implementation was ineffective. So without knowing exactly which aspect of implementation was ineffective, you wouldn't know how to remedy that issue. So that's another major reason why we do that.
That's helpful. I mean, I appreciate all that framing. Teo is asking, should there be a National Institute of Implementation Science?
I could probably make an argument both ways for this, honestly. In some ways, implementation science it's a methodology field. So, I, personally am trained as a clinical psychologist. The majority of my personal work is actually preventive and management services for kids within primary care. So I focus on hypertension as well as obesity and mental health, but largely with a pediatric population and in the primary care setting. So it's kind of narrow in terms of what I personally lead. But a lot of my work, as was kind of mentioned in the introduction, I work across cancer, I work across adult cardiovascular health, work obviously within HIV and infectious disease. and actually have some likely funded grants now that are going to be in human genomics and genetic counseling. So, it's one of those things that because it's methods focused, it has broad application across all the NIH institutes and centers, in which case it kind of seems to me like it could be similar to like the structure of OAR or OBSSR within NIH. Maybe it's like, a thing within the office of the director. But the other thing I think that's kind of interesting too, and I think we're seeing this a little bit, but I think probably not as much as some folks thought we would, is as we dig into sort of the implementation strategies that people use that are kind of field specific. So I think, we got this actually 3 or 4 years ago when we established a inter-CFAR working group in implementation science, is, we kind of made the point that we want to like learn from the broader field, and we want to, kind of bring in the best and state of the science of implementation science to HIV. And we actually have multiple people who said, but why? We do things so differently. We need to have our own definitions. We need to have our own like field of HIV implementation science. And those of us who work across fields already, we're, kind of like, no, we don't. Like it's not necessary. That we have generalizable models, we have generalizable methodology, generalizable theories. And so there's been other fields too that have tried to say, or tried to essentially look at whether or not there's something like super unique happening, I guess. And there's some differences for sure. I mean, when you're talking about like school-based mental health, the school system itself is so kind of unique in comparison to everything else that, naturally you'd have some certain things. But in HIV, because we're working in similar settings as lots of other things like vaccinations and other STIs, it doesn't necessarily make sense that we'd have to have our own thing. So right now, the way that everything's structured at NIH anyway is that a lot of them have implementation science branches, or even like NHLBI has an actual center for translational and implementation science. But I think that there potentially is a centralized office would be potentially really beneficial to the field, because these kind of different sects kind of develop independently and they don't necessarily progress always at the same pace. And so that means that some ICs and some areas of science are basically getting left behind.
Yeah, this is Bob again. I find it interesting that a little bit of the evolution we're seeing at the NIH itself. I think historically NIH has always said or felt like they are science of discovery, and I've had conversations with people, like Carl Diefenbach or even Tony Fauci, saying, well, CDC does implementation, or that's where that should take place. But yet there's been an evolution to that, right? I mean, with the all these supplements and things you've described out of NIAID and NIMH, they've taken on implementation science as part of discovery.
Yeah, I think your wording there was really critical, Bob, that NIH has embraced the science of implementation.
Yeah.
But I think they still do view, and I think rightly so, CDC and HRSA in particular are the implementers.
Right.
And what I think has been lost in the couple of decades where NIH really kind of shunned implementation science, saying that's somebody else's responsibility essentially, is that there wasn't the kind of cross and backwards learning. So there's a lot of things that we can learn from people who know how to implement. The issue with CDC being the implementer is that they don't fund research. So we can't really even evaluate in most circumstances exactly how that implementation happens, what makes it effective. There's a number of examples of places where CDC pushed out lots of money to implement things, and the implementation largely failed. And we don't have lessons learned from that either, at least not systematic ones. So there's a bit of there needs to be kind of a two-way street where we're conducting research and learning best practices, feeding into the use of those best practices in science by the implementers themselves, because that was also being lost without having a science of implementation. But yeah, you're totally right. They have really shifted, but there still, I think, is a pretty big bastion within NIH that does not view implementation as part of their purview, unfortunately.
Mm-hmm. Let's see. Questions are popping in now. Teo has another question here related to what we're just talking about. So let's go there first. Would you argue that there is little use of funding non-implementation science HIV studies?
That's a really good question. I mean, the very pragmatic side of this argument is that we have what we need. I think there's always room for improvement, though, and I think going back to pre-exposure prophylaxis as an example, it's highly effective, but has to be taken once a day, at least within the original Truvada format. Developing long-acting PrEP and some other methods that sort of reduce the potential for low fidelity or low compliance is only going to improve the outcome. So there is still places for advancement and for discovery to play a major role. I mean, this is never minding even if we could find a cure, of course. But I do think there still is a place for non-implementation science HIV. What I think we need to move towards, though, and this is, I don't know if the Truvada example is a great one or not, but sometimes there's a lack of foresight in terms of how implementable and how acceptable certain innovations will be. It hasn't necessarily been as big of an issue in the HIV field, but in behavioral interventions, mostly for mental health and substance use, there's been a huge mismatch between the kind of Cadillac, evidence-based programs that have been developed and what could actually ever be purchased and implemented and, delivered within the current service delivery system. I mean, mental health is just not equipped to deliver the complex interventions that are currently being developed. So I think regardless of field, any new innovation needs to take into account, consider, and not make things that are not implementable. And there's a kind of a movement in the field that's called designing for dissemination or designing for implementation. There's also a really cool framework that was published last year in Journal of Clinical Translational Science that's called Designing for Accelerated Research Translation, that really talks about this issue of, if whatever we develop, we have to make sure that it can be readily implemented, that we don't have to continually adapt. We don't have to do all these things to make it work. It needs to just fit better from start to finish.
Thank you for that. And I saw Karen McKinnon applauding your response to this last question. And she also has a question in the chat. And Karen, of course, like everyone, feel free to unmute yourself and elaborate on your question. But she asked, could you say a bit about the evidence in support of the interrelationships of the IRLM components, determinants, strategies, mechanisms, outcomes?
Sure. So I think the easiest evidence one is the strategies to outcomes. We definitely know that certain strategies, mostly because they align with the level of the outcome of implementation and research, that there's good evidence for that relationship. There's a lack of synthesis evidence. And there's a number of reviews that have talked about the challenge and problem of trying to synthesize implementation strategies. Mostly that people use really different terminology. And so it's really hard to know, is this thing exactly the same as this thing? It sounds similar, but maybe it's not. There's also a major lack of detail. But notwithstanding, the other one I think that people have been trying to make better evidence for, or find better evidence for, is the determinants to strategies link. Byron Powell and some of his colleagues have a really nice paper where they tried to match up essentially the consolidated framework for implementation and research barriers with the ERIC compilation of implementation strategies. And it was more of like a conceptual linking, but was based on some empirical evidence that people had accumulated. And what they found is that it's really not great. The actual matching approach didn't really work super well. So I think this is more of a conceptual evidence, and I think it's one that people sort of intuitively understand that these things should be related. But the strong, overwhelming, unambiguous empirical evidence is not quite there yet, at least not for each of them. And then mechanisms is kind of the really weird one in terms of, there has only been a kind of major push to start to understand the mechanisms of implementation strategies and why they actually work over the last 2 or 3 years. Before that, there was a real dearth of studies in this area. And I think it's going to continue to grow, and there's going to become a science of the mechanisms of implementation. But right now, that was a bit kind of on the not necessarily aspirational, but sort of the forward-thinking side to include that.
Thank you.
Thanks, Dee.
So Graham Harriman, our colleague from the New York City Health Department, writes, I'm from the New York City Ryan White Part A program. Can you give me some first steps on how to use implementation science in the programs we are funding now and for those we will fund in the future?
Yeah. So,
Let me just give a little more context. Just so,
go ahead, Graham.
we've done some training of staff around the different models of implementation science, but we sort of want to begin to employ implementation science from the point at which models are created in the Planning Council and all the way through the RFP process, the awarding process, the technical assistance, the collecting of data, and wondering how do we set this up so that it works for large programs as a part of public health.
yeah, really good question. Again, this is something we're actually not great at, but I'll give you my best take on this. So there has been some evidence that actually just being adherent and following a implementation planning and execution framework leads to better outcomes. So that was a study that was done by the Penn State Epicenter a few years ago, where they pseudo-randomly assigned these community-based programs to either basically get implementation science support, which really was like, we're going to follow this implementation framework, or not. And they did find that those that got even the minimal amount of support around following the framework were more likely to actually adopt the program and actually deliver it to patients, but then had better implementation outcomes than the comparison projects. So that's one really easy one, is to start early with a planning and execution related framework, something like the EPIS framework. The Getting to Outcomes framework is a nice one as well. And there are others that sort of take you through the process of what needs to be considered, what are some of the steps, and the sequence of steps that happens that we know is related to better implementation down the road. The other thing is really, and this goes back to just and kind of including into the required metrics and required evaluation metrics, is to include implementation metrics. A lot of people who are doing program evaluation are still focused on things that really could be reconceptualized as implementation outcomes. So, sometimes to reporting back to funders, we say how many people, actually received the program. And, if my community-based organization says, yeah, we gave it, we tested, 2,800 people, for HIV, that sounds like a nice number. And, depending on how much funding they got, it might actually be really good bang for the buck. But if they serve a population that had 180,000 people who are eligible to get tested, that all of a sudden is not a very impressive metric at all, regardless of the amount of funding. It just means they're not reaching a lot of people. The other thing, I think those are the two biggest things. I think the third thing, which is a little bit more challenging, is really to get people to think more systematically about the implementation strategies they use and potentially a little bit of why. A lot of times we have kind of implementation processes as usual, and in certain organizations they're fairly well polished, they work really well, and that obviously is very conducive to being successful. But in other situations, maybe they've had variable success in prior program implementation, and one of the ways that you can improve that is to have more formal specification and use of evidence-based implementation strategies as they implement.
Thank you. And are there specific resources that we should engage with to use them for our program? Yeah,
so I think one group that's done a good job and really they really focus on the actual implementer perspective. So they try to bridge this integration of research to practice, and are much more heavy on the practice side, is the National Implementation Research Network, or the NIRN, which is affiliated with UNC Chapel Hill. So they have a great website. They have a lot of freely available resources. They also do trainings and of course do technical assistance. But that would be a great organization to potentially try to connect with, at least for some ideas at the starting point.
That's great. Thank you so much. I really appreciate it.
Sure.
We have a question from Stephen Sawicki asking, how does IS fit within CQI?
Great question. I'm going to give you a very basic, maybe slightly hyperbolic comparison, but hopefully it makes the point. So What we typically think of in CQI is the purpose is really to generate local knowledge. It's really to figure out, how do I improve my program? How do I make sure it stays good within my particular system, my setting? And really that's the goal. Within implementation science, although you can borrow, findings and models and potentially kind of use some of the things that implementation science has done, the goal of actual implementation science is to use methodology that creates generalizable causal inference. So it would not be specific necessarily. It might still work, but it wouldn't necessarily be specific or only effective within one particular setting. So some of the methodology that we use really kind of has an understanding that you're going to have multiple units. It's going to be randomized potentially, or quasi-randomized, or at least have a higher level of rigor than CQI would. What we see is kind of a melding of the two, is that CQI can use some of the metrics, can use some of the models and frameworks, and certainly can borrow from the findings of implementation research to figure out which strategies you should use for continuous quality improvement initiatives. So there's definitely a nice kind of crosswalk in places that they can borrow from each other. I actually had a presentation that I recorded, I guess, a week or two ago for the NIH D&I conference that will be, I think, on December 14th, where we actually developed a rigorous implementation research trial design that is very highly overlapping with CQI. Which is we call it the Rollout Implementation Optimization, or ROIO design, which has to do with kind of a stepped wedge type trial design where there's intentional improvement across the clusters. So it's not within a site, it's actually across multiple sites. And the idea is to try to improve the package of implementation strategies that you're using for the implementation of one intervention across multiple units. In most, stepped wedge studies, you would not want that. They're sort of treated as a nuisance almost, that if you kind of learn mistakes and you improve, you have to control for that statistically. Intentionally trying to use data and engage partners in a way that each time you move down the step or move down the cluster of clinics that you implement in, that you improve upon the prior. And so I think there's myself and some others, have certainly been trying to figure out more effective ways of kind of melding improvement science and CQI with kind of what implementation science is trying to do. So yeah, there's definitely a cross-pollination, but yeah, we're not quite there yet.
And I noticed that Stephen Sukumaran put in a link in the chat to the National Implementation Research Network that was mentioned. Thank you, Stephen. We only have a few more minutes. I don't see any other questions at the moment. JD, I'm wondering if you'd like to just, Stephen, think out loud a little bit about something that I think is very timely in terms of COVID and COVID vaccination, and your thoughts about its ripeness for implementation at this point. Of course, I think there's still a lot more outcomes that we need to see in terms of effectiveness in the real world, but I don't know. I just invite you to opine about that a little bit.
I would love to. So, I think the really obvious thing, we saw this already with the Pfizer and Moderna vaccines, that one of the huge implementation challenges, just because of the nature of the vaccine, is sort of the supply chain and the actual delivery chain, where the Pfizer vaccine requires super cold storage, whereas Moderna does not. So that's only yes, very relevant, incredibly important for states and other organizations and hospitals and everybody to know and figure out how to actually get that into a place where it could be injected into someone. But I think what it does is that's sort of an oversimplification of what is needed. That those are certainly major issues, but one thing that's been really kind of ignored, I think, at least in listening to kind of the popular media and news outlets reporting about what kind of what the vaccine rollout might look like and how we might implement, is that it's very general. And so, especially in the United States, there's sort of an assumption of similarity across different populations, across different states, and a nurse is a nurse is a nurse, regardless of where you live, which is really not the case. And so there really cannot, I don't think there cannot be an effective implementation strategy for everyone. And part of this is both, geography and service delivery systems, as well as kind of the nature of different people's jobs and the things that they do, where they would, maybe be on the earlier versus later side of getting vaccinated. But the other piece that it kind of ignores is, the individual, kind of perspective about vaccination. So we know we have anti-vaxxers. We also have this kind of people who are reluctant to get vaccinated, and the implementation strategies that might be necessary to motivate and encourage and get people to shift that and be accepting of vaccination could really actually be tailored a little bit better. So we really do need to consider kind of where people are coming from, both on the receiving side, but also on the delivery side, and tailor implementation strategies specifically to address those contextual factors. So, again, I think it's just kind of going back to, I don't think there's going to be a one size fits all. And if we try to go that route, it's likely to fail. So that's my little thinking out loud.
Yeah, no, I appreciate you doing that. So this was great. JD, I want to thank you again for a really great presentation and also an excellent and rich discussion here. So thank you for taking the time. I also want to thank you for spending time coming up with our postdoctoral fellows. You're being very generous today. And to everyone, just have a good December, have good holidays, stay safe, stay healthy, and we'll see you at our grand rounds back in January in the new year. And let's hope for a uplifting and optimistic and better 2021 than 2020. Thank you, JD. Thank you, everyone.